Okay, so welcome back, everyone. So in this session we've got 2 talks and 2 live cases, and I'm very pleased to welcome Fumobi Yoshimachi from Japan to give us a talk in this next session on today's slender techniques. So thanks very much for starting the program.
Good morning, ladies and gentlemen. I'm very happy and I'm very honored to be here. So I'll talk about today's slender technique. But I always use basic and essential slender technique, but please check our presentation. It's okay?
Good.
Okay. So reduction in size of all devices of PCI, including the guiding catheter, is one of the great advances during the past 10 years. However, some physicians worry about the limitation of slender PCI, especially backup support, backup force of guiding catheter. So which is better for the patient? So we are interventionalists, so we select intervention. And which is better for the patient? H French or 5 French? Which is better? Which do you like? Just I like slender. So comparing each side of guiding catheter, there are some very different cross-sectional area. We think slender catheter is better, but some doctors 7 French is better because of big power. So which is strong? Which is better? So of course, big arm is strong, but there's no meaning to compare the power, in my opinion. So what is backup? Backup force. Large diameter guiding has big stiffness, but we don't need test of strength. So what we need is only supporting the power of reaction to advanced devices. In other words, we should use a little ingenuity to make minimum power to advanced devices. So in coaxial position, it's good position. The direction of the guiding catheter is the same as the direction of advanced devices. Big powers become unnecessary. So if slender catheter can be put into the coronary deep slightly, a more effective coaxial position can be made. So sometimes it's necessary to deform the shape of guiding catheter in aorta, and to make the form, we call it power position. So for example, when we treat LAD, we make this position alpha loop engagement. After engagement of a Judkins type guiding catheter is advancing with a small clockwise rotation to form an alpha shaped loop as contact aortic wall. So this is how to make the alpha loop position. If we make this position, we can get great coaxial. This is a shape. Right figure is normal engagement, but left side is alpha loop engagement. That is very good power position for us. So first normal engagement, we cannot put inside the cipher stent, but if we make alpha position, it's so easy to insert the cipher stent. So this is a special technique to alpha loop engagement. We call this M plus new close technique. This is the diagnosis catheter. And you can see the stenosis. The stenosis is slightly proximal to stent. That is a stent proximal restenosis. So the guide wire inserted in the diagnosis catheter. And with NANT method, diagnosis catheter was removed. Just only remains the guide wire. So you can see the good alpha loop position of guide wire. Inserting the IVUS and check the region. And pre-dilatation was performed. And inserting cipher stent. Can you see the guiding catheter? Just only use the guide wire. So deploy the cipher stent. So this guiding catheter is only wise man can see the new special slender catheter. So it's called the M plus new cross technique. So after that, check the IVUS. Finally, diagnosis catheter was inserted, and angiography was performed for checking the perforation or anything. So if we make the good position and coaxial position, not so good, not so rigid guiding catheter is necessary. However, sometimes it's impossible to keep coaxial position with only guiding catheter or guiding wire. We need other devices to make a good stability and coaxial position. This is the CTO cases, right lateral approach. It's M+1 5 French. It's difficult to make the coaxial position with Jazkin type or something. So first, I use the hydrocoat wire to insert the RV branch. After that, Corsair was used like this one. Corsair has some screw that is the resistance. That makes the resistance, and we make the coaxial position of occlusion site and tip of the Corsair. Guide wire was exchanged to Wizard 78. That is the Japanese tapered guide wire, very flexible guide wire. So, if the coaxial position was made, the guide wire was advanced slightly, and the guide wire was stopped at here. So, guide wire was changed to the Confianza Pro, and only 1 millimeter or so advanced the Confianza Pro. The guide wire was changed again with that 78 very flexible wire, and it can be advanced like this one. The guiding catheter is not coaxial, but we can make the coaxial position with just only Corsair. So after that, how can I do? Corsair cannot advance from here, so I use Tornus Pro. Tornus Pro has a more rigid and good screw type of the tube. After inserting the Corsair to deep layer and guiding catheter was make the coaxial position like this. And pre-dilatation was performed with 1.0 millimeter balloon and 2.0 millimeter balloon. And check the ribs, and Giants was inserted from here to here to Giants. This is the final position. So if we can make the coaxial position, CTO region can be treated with slender catheter, post-dilatation. This is the final. And sometimes anchor balloon technique was very good to make the coaxial position and helping us backup support. But to use anchor balloon technique, 6 French or 7 French guiding catheter is needed for 1 balloon and 1 stent is needed. So if we need 5 French or 4 French guiding catheter, we cannot use anchor balloon technique. So sometimes use gel stent technique. That is this one. If the stent was can deliver it here, and if there are some proximal region, stent was deployed at the proximal region, and one guide wire was gelled at here. After that, it's very easy to cross the region because of the support of gelled wire is very good. So this is a case. And you can see the very calcified region. And we want to treat 2 positions. From proximal of bifurcation and mid of RCA. And 1.5 balloon was used for pre-dilatation. But result integrity can't be crossed from the proximal region because of the very calcified. So, result integrity was implanted at the proximal region with high pressure. And one guide wire is gelled at the, by the stent. After that, it's very easy to cross the region and make a position, and result integrity was implanted at here. And post-dilatation was performed. So this is a final angiography. And sometimes good manipulation and control of guiding catheter is required on slender PCI. That's a basic and fundamental technique. For example, operators should be good using multi-purpose type of catheter for right and left coronary angiography. Because of slender guiding catheter, it's soft, and 5 French guiding catheter is very soft and flexible, so it's very easy to use bilateral coronary angiography with Judkins left type guiding catheter or Kimini type of guiding catheter. This is the case. You can see the CTO of the LAD. That is a short type of left Judkins type of 5 French guiding catheter. So So support capacitor is fine cross MG, and fine without 75 guide wire, it's a tapered guide wire of Japanese. The guide wire is advanced from here. And without 3, it's slightly hard guide wire, tapered guide wire. So the guide wire is advanced, but where was the tip of the guide wire? And contralateral indication was needed. So what should we do from here? One of the answers is that. Do you understand? So this technique is introduced by Dr. Kimuni and named 1P1G, one person, one guiding capacitor. So we can see we can check the guide wire is correct position or not. Like this one. So after checking the position, guide wire is reversed again, and small balloon was used. And 2.0 millimeter balloon was used. And checking the IVUS. Stent was deployed, 1 stent, 2 stent. This is 2 stent. So this is the final angiography. So if we can good manipulation, one puncture and one guiding catheter is performed available. So totally, we can. Sometimes it's rather difficult to perform the retrograde approach because of some of the physicians said it needs very very big pushability. But in my opinion, the pushability is not so required. This is a cases. You can see the total occlusion of LAD and 5 French short type of Judkins type was used. Like this one. So tapered guide wire was used, but it's rather difficult to cross the region, and we can see the fourth lumen in the guide wire is in fourth lumen. So the strategy was changed to a retrograde approach. 5 French Amplas type of guiding catheter was used, and using Corsair. And XTR was used. It's the same as 7 French or 8 French straight, 8 French of planning. And using how to use it is the same as 5 French or 8 French guiding catheter. There is no concern of using the retrograde approach. So tip injection was performed. And after that, it's very difficult to penetrate the distal site of occlusion site. So Confianza Pro was used to penetrate, and knuckle wire technique was performed. This is the IVUS finding. We can see the retrograde wire at that. So reverse cut technique was performed. And going to the guide wire was advanced to the fourth lumen and it connected to two lumen. After that, not so difficult intervention, only predilatation and stenting, and post-dilatation was performed. So if the retrograde approach, we can perform the 5 French guiding catheter. Like this one. So what we need is not big power, just only how to and delicate manipulation. So in Japan, we have Japanese art of tea ceremony. We call it sado. Sado is not just only drinking tea. Sado is very good to study how to drink and how enjoy the drink, the tea. So when enjoy the drinking tea, there is no meaning to compare the power. So that is our habit to tea ceremony or anything. Maybe our friend of European doctors or our foreign doctors can understand this how to, and in Japanese, omotenashi mind. So less invasive PCI is performed with transradial intervention and slender devices and techniques. Making better use of these devices and by selecting the region, effective slender PCI is performed. So thank you very much for your attention.
Thanks very much. Amazing technical expertise. We're a little bit behind with the program, so we're going to go straight to the live case.